Hi everyone and welcome to tonight's IIOP webinar. My name's Emily Kelly and I'm one of the peer support pharmacists. The topic tonight is the HSE Addiction Treatment Service, the pharmacy focus. So just a few domestics before we start, but to remind everyone to keep their microphones on mute. If you've got any connectivity issues, you can try logging in or logging out. Just make sure the volume on your computer is up if it's a sound issue. And sometimes you might want to turn your video off if that helps with connectivity. The webinar is being recorded as well. And there we go. Thanks a million, Grace. So yeah, microphone's muted, video's on and off, and the difficulty with sound. Questions throughout, you can put them in the chat box as and when you think of them. And at the end of all the speakers, we will have 10 minutes to go through any questions that are asked. We may use some anonymised information from the webinar. And finally, we normally have the post-webinar survey at the end, but that will be in the chat box for you to give feedback. And Grace has just popped it in there for you to give feedback on tonight's webinar. So we have a fantastic evening up for you with 5 different speakers. So I'm going to hand over now to Niamh Kilcullen, Chief II Pharmacists from the Addiction Services, and she'll introduce the other speakers for the evening. Thanks a million, Niamh.
Hi. Thanks, Emily. So my name is Niamh Kilcullen, and I'm one of the Chief II Pharmacists in the Addiction Services. I cover the geographical area of Dublin South West and West Wicklow, and I'm going to speak this evening on an overview of the Addiction Services. The other speakers this evening then are Mary Egan, who covers the area of Dublin South, East Wicklow and Kildare, and she's going to speak about methadone. Blaithin Cotter will cover buprenorphine, and Blaithin covers the area of Dublin and the North East. Meghan Lynch is based in the National Drug Treatment Centre, and she's going to speak on current drug trends. And Norma Harnedy is going to speak on harm reduction, and she is the National Chief II Pharmacist, excluding Dublin, Wicklow and Kildare. Sorry. So the learning objectives for my section of the presentation are to know the role of the Chief II Pharmacists in your area, to know how to access services if you have a client who would like to access services, to have an understanding of the services that are provided within the addiction services, and to know how to order methadone for palliative care or pain. So I've put together a slide of all our contact details, which will be added as a resource to the IOP website after the presentation, in case you do want to contact any of us at any stage. So just using myself as an example, these are the roles that the Addiction Services Chief II Pharmacists cover. So we're responsible for liaison with community pharmacy within our own geographical areas. So that involves placing patients in a community pharmacy to receive their OAT. The pharmacy needs to be registered and geographically suitable for the patient and have opening hours that allows them to obtain their OAT when they need it. We're also approval for OAT grants within our area for pharmacies that are eligible for them. And then we manage the pharmacy services and staff in the treatment centres in our area. So the ones in my area are listed there on the right-hand side of the screen. And then we cover the roles that many Chief II Pharmacists across the country. We all are involved in education and training and being a member of Pharmacy and Therapeutics Committee. But we would then all have certain roles that would be individual to us. So for example, I'm a member of the South Inner City Drugs and Alcohol Task Force, and I'm the HSE representative on that group. So if somebody's looking to access addiction treatment services, of course their GP can refer them, or they could be referred during a hospital visit or a hospital inpatient stay. But if somebody came into your community pharmacy and was looking to be referred, a good protocol is the HSE Drugs and Alcohol Helpline. It's a national service that operates 9:30 to 5:30 Monday to Friday, and they're accessible either by phone or by email. They have information on services nationwide, although they are based in Dublin. Referral can also be by community-funded services such as Merchants Quay Ireland. So I'm going to start with the National Drug Treatment Centre. So it's based in Pearse Street in Dublin. The patients who attend the NDDC are generally homeless or have been transferred there for behavioural issues. And while the NDDC is within the area that I cover, I don't have any jurisdiction over. Sorry, somebody not muted there. Thanks. Yeah, I don't have jurisdiction over it. Meghan Lynch is the Chief II Pharmacist for the NDDC and is responsible for pharmacy services there. So the care is provided by multidisciplinary teams, which is led by 4 psychiatry consultants. And prescribing is also carried out by registrars on the GP scheme who rotate every 6 months in line with GP scheme. So this differs from the prescribing in the addiction treatment centres elsewhere in the HSE, which is carried out by GPs who would be working there in the longer term. The National Lab for Drug Testing and Drug Trend Monitoring is based in the NDTC, as are the Central Treatment List offices. And there are additional clinics available to the patients attending the NDTC, which would include a Hep C clinic and an ADHD clinic. Pharmacy services there provided include, of course, OAT supply, but they also supply many other medications as the patients are generally homeless and they may not have access to another GP. So the Central Treatment List, the contact details are there in case you ever need to contact them. They maintain a national register of all patients receiving OAT in Ireland, no matter where they are receiving it. They keep all the key metrics for a patient, but if you are to contact them, please make sure they have their correctly spelt patient name and their date of birth, because they're the first two things that they will look for. And they issue the treatment card to the community pharmacy before OAT can be supplied. And now this is always sent via health mail. Hard copy is not sent out. They will also issue a cessation notice via health mail. So if somebody is to be no longer supplied OAT from your pharmacy, this will be notified via health mail as well. The addiction treatment services then are also provided through the addiction treatment centres, or what would be commonly known as clinics. And the dispensing clinics are listed here, and they are throughout the country. There are then also HSE scripting only clinics where a GP will provide a prescription and the medication needs to be supplied by a community pharmacy. Community GPs can also provide prescriptions, and there are a number of residential care beds nationally. If you want to find out information on clinics and services in your area, all the information is available on hse.ie if you follow the links for social inclusion. And information on some of the voluntary services such as MQI or Kilcullen are available on drugs.ie. So the staff in addiction treatment centres are listed here. So as you can see, there's a large number of different professions working within the treatment centres, and this allows us to provide wraparound care to the patients attending. It's really great that people can come in, and if they need to see a nurse, they can see a nurse, or they can see a doctor, or get the help that they need when they need it. So the pharmacy services provided are obviously primarily dispensing of OAT and primarily medications related to mental health, although as in the NDTC, other medications are supplied when patients need them, and vaccines are provided and administered by nursing staff, such as the flu vaccine or hepatitis vaccines. Hepatitis C treatment can be provided in the clinic, and testing is done within the clinic, and then if needed, the pharmacist will dispense hepatitis C treatment along with the OAT. Naloxone education supply is very key at the moment. A lot of promotion around naloxone, and that can be done in the clinic too. Of course, we participate in detox programs and also the HIV medicines management. So if patients are on HIV medication provided outside the clinic, they are welcome to bring it into the clinic, and the pharmacist will store it for them and supply it with their OAT with compliance. So community treatment, GPs have to be trained to be able to prescribe methadone, but all GPs who graduate now are trained to a level where they can prescribe. They have to have a level 2 qualification to be able to initiate or stabilise patients. Service users are placed with a GP by a GP coordinator, so they need to be assigned a GP specifically, and then they are placed in a community pharmacy by the addiction services liaison pharmacist. If a patient needs to be transferred from one pharmacy to another, the GP or the pharmacist can fill in a pharmacy transfer request form and send that on to the CTL. They will then contact us or the GP coordinator as appropriate and arrange to have the patient relocated if appropriate. And these forms are available on the Drug Treatment Centre website. So just to mention methadone for palliative care and pain, it's not something that we're actually involved in, but it is something that we get queries on for a fairly regular basis. So I put the information here, and the pharmacy circular there is good reference if you are involved in this. Pharmacists need to email the Social Care Division of the Department of Health to request the restriction on ordering to be lifted in this case, and the GPs need to email the same address to get authorisation to obtain prescriptions. Neither the GP or the pharmacy need to be registered with CTL, but the prescribing must be carried out on an OAT protocol prescription form. So I'll pass you on then to Mary for her section presentation. Thank you very much.
Mary, I think you just need to unmute yourself there for a second. Yeah, thanks a million. It's down near the bottom where it says audio.
Should be the bottom left.
The bottom left, yeah.
Can you hear me?
There you go. Perfect, Mary. Thanks a million.
Sorry about that. So I'll start again. My name is Mary Egan, and I'm going to present on methadone in the treatment of opioid dependence. So I have a good few slides to get through, so I will go through them at pace, but it's really kind of to illustrate some of the important areas of methadone treatment without going into too much detail. So in terms of the history of methadone, until 1996, the only form of methadone medicine available in Ireland was Fiseptone, and that was available in a 2 milligram per 5 ml strength. In 1997, then, the Health Board decided it would recognise methadone treatment in Ireland, and this meant phasing out Fiseptone Linctus and transferring everyone to methadone mixture. And this was a stronger strength of 1 milligram per ml. The change initially happened in clinics and then in GP surgeries. So that's just a little brief history of where methadone was first recognised as a treatment and approved treatment in Ireland. So in terms of the chemistry and chemical receptor activity of methadone, there appears to be two active sites in the molecule. So the nitrogen atom with the hydrochloride bonded to one end is thought to act on the peripheral nervous system. The two phenyl rings then are thought to be necessary for opiate-like action on the central nervous system. So with receptor activity, methadone is a full opioid agonist. It binds to the receptor, producing a dose-dependent increase on physiological effects. Higher doses reduce cravings for and effects of other opioids. So with this visual, you can see it's an opioid receptor. The opioid receptor is empty. So as someone becomes tolerant to opioids, they become less sensitive and require more opioids to produce the same effect. Whenever there is insufficient amount of opioid receptors activated, the patient then feels discomfort, and this is what happens in withdrawal. And with this visual then, we have a receptor, opioid receptor with a full agonist. So the strong opioid effect of heroin and painkillers can cause euphoria to stop the withdrawal. The brain then begins to crave opioids, sometimes to the point of uncontrollable compulsion, and this is addiction, so where the cycle escalates and repeats. Sorry. Okay, so this graph here illustrates the relative blood levels of methadone over the first 4 days of treatment. So methadone itself binds to the cells in the liver, lungs, fat before moving back into the bloodstream. It is harmless and does not damage cells, and the patient will not get full effect of the dose initially. It would take 4 days for these tissue reservoirs to fill up and for the methadone to take full effect. So as you can see from the graph below, there is less methadone in someone's system at the peak on day 1 than there is before the dose is even taken on day 4. So it takes around 30 minutes to start being absorbed and 4 hours to reach peak blood level. So effectiveness of methadone, it has ideal properties for a maintenance agent. It is orally active and long-acting. It enables patients to function normally. It has the ability to suppress craving. It is well absorbed after oral administration, as I've previously stated. It is extensively metabolized in the liver, and the elimination half-life of methadone is approximately 22 hours, but there is considerable inter-individual variability, and estimates can range from anything from 5 hours to 130 hours. With methadone, we have phases of treatment, starting with induction, stabilization, maintenance, detox. If a patient relapses, unfortunately, then they have to be reassessed and they would have to start at the induction phase again. So that's the arrow going back to induction. Unfortunately, that can happen. With the phases of treatment, we would refer to our OST guidelines here. So dose induction with methadone should aim to achieve an effective dose while exercising caution about the inherent risks of too rapid an increase. So it should be commenced by suitably trained level 2 GPs and HSE addiction clinic prescribers. Initial dose can be between 10 and 40, depending on patient assessment. We generally start on 20 milligrams as a safe starting dose. If point-of-care testing is done, it will determine that there is an opiate in the patient's system, but it can't determine the levels or the actual opiate. So all it gives us is that it's an opiate positive result. So that could be anything from heroin to 2-Nervin plus over the counter. So as a safety precaution, 20 milligrams would be seen as a safe starting dose. The initial dose should be maintained for at least 3 days to ensure that the effects of methadone can be fully assessed. Frequent monitoring, daily supervision, carers should be alerted to signs of overdose and watch for drug interactions. Dose increases should be done at a maximum of between 5 and 10 a day, and we would recommend no more than 20 in a week. So with stabilization, this is a phase to achieve a dose that treats withdrawals, cravings, support the patient in achieving a healthier lifestyle. It can take up to 3 months, and suitably trained GPs involved again. Doses can vary between 60 to 120, and obviously that can range upper or lower of that range, but somewhere in between would be sort of the normal range of doses. So, and the dose increase again applies of no more than 20 in a week. Maintenance, once stable on methadone, we would recommend at least 1 dose per week should be supervised. This should also apply in community pharmacy on your OAT prescription, and if it's not ticked the supervision box, then that should be really clarified with the doctor as to why that there's no supervision. But we would always recommend 1 dose per week minimum. There should be no dose reduction as a sanction for ongoing illicit drug use. And this phase can be undertaken by suitably trained level 1 GPs, as Niamh mentioned earlier, and level 2 prescribers in the HSE addiction clinic. It relieves withdrawal symptoms, blocks opiate-induced euphoria, or reduces and eliminates cravings over 24 hours. The requirements to increase doses once the patients have stabilized are usually infrequent. So the level 1 prescribers can seek further advice from referral agencies like level 2 GPs or HSE addiction clinic when considering a dose increase. And again, the dose increase should be carried out with those ranges that I mentioned, 5 to 10 in a day and 20 in a week. Detox should be mentioned to patients as part of their care plan, because this, unfortunately, it's a small minority, but it still should be the ultimate goal. So this is the period which dose reduction and discontinuation of OAT takes place following stability of drug use. So detailed information should be given to the patient, including physical, psychological aspects of opioid withdrawal, non-pharmacological approaches, and explain that the loss of opioid tolerance following detoxification, that should be explained to the patient. And the importance of continued supports should also be made aware of. So with missed doses, I've just put a slide up here because it seems to vary according to whichever workplace you may be in. With the addiction services, we would refer to our OST guidelines. So for instance, if a patient misses 3 days, the prescribing doctor would reassess, and more than likely there would be a dose reduction. And if the patient is due an increase or misses a day's dispensing or is missing for a number of days, then this increase will not be dispensed. With hospital, we're using a sample protocol from James's Hospital, who kindly allowed us share their protocol, where they actually put a great table together on time elapsed since last dose and actions. So they have between 48 and 72 hours usual dose can be prescribed, and as a caution, this can be given in 2 divided doses over the first day. If it's between 72 hours and 5 days, prescribe half the patient's usual methadone dose, which should not exceed 40 milligrams, aiming to return to the usual dose within 5 to 7 days, and usual increments of up to 20 milligrams per day. And anything over 5 days would be treated as a new induction. We are using then Lloyd's OAT dispensing procedures as a sample of a community pharmacy protocol. So if a patient misses 1 day, dispense full dose, 2 days loss of tolerance, and discuss the agreed protocol with the prescribing doctor. And 3 days or more, the prescribing doctor needs to obviously be contacted, because more than likely there might be a dose modification. So I suppose just to reiterate, missed doses and all of those things that kind of pop up with with our patients, it's just really recommend that agreed protocols are in place for each workplace. So just side effects and interactions: sweating, constipation, aching muscles, lowered sex drive, that can often settle after the patient has stabilized on methadone. Skin rashes, sedation, loss of appetite, abdominal pain, drowsiness. Oedema is quite common, puffiness in the hands and feet especially, nausea and vomiting. Obviously, interactions like CNS depressants and QT prolonging medications, which I'll mention in a second, but I have that up as a resource on the IOP website. I just wanted to mention methadone in pregnancy. So with opioid-dependent pregnant women, they should not be required to reduce or come off OAT in pregnancy, because this may be an inappropriate intervention and may lead to unnecessary risks with pregnancy. So the main objective is to maintain stability for the duration of pregnancy, especially in the third trimester, and it should not be encouraged because it can lead to mild maternal withdrawal, and that can be associated with fetal distress and stillbirth. So what I've done is, it's up on the resources as well. I have the drug liaison midwives' contact details and the hospitals that they're all linked to. So it's a fairly useful resource. I just wanted to mention in the next slide, the risk of QTC prolongation. We would carry out yearly ECGs on our patients on 100 milligrams of methadone or more, and obviously SSRIs as well. If they're taking SSRIs, that would be recommended that we would carry out ECGs. And certain medications like domperidone and over-the-counter meds, we would try and steer clear of. We would use metoclopramide. This can increase QT prolongation and should be avoided with methadone. I've provided a table there with drugs that can prolong QT interval, and there's a link to the slide that you can individually look at drug interactions. So for my remaining slides, they're all up as resources and links to further reading. So thank you. That is my presentation. I will now pass you over to my colleague Blaithin.
Okay. So good evening, everyone, and thank you for joining us. So my name is Blaithin Cotter, and I'm the Chief II Pharmacist. My area is Dublin North. I am manager for the pharmacy staff working in our addiction treatment centres, and I also liaise with community pharmacies around treatment placements for OAT. So buprenorphine, I'm going to talk a little bit about this evening. Just to say, the availability of buprenorphine has been a very positive treatment option for our service users. It gives another choice to service users, where methadone has been the only option actually for many years. A service user survey that we conducted quite recently in the Dublin North area, the results showed that there was pretty strong criticism from many service users about the lack of choice. So I'm hoping after the talk this evening that maybe as pharmacists you feel more confident and more knowledgeable about buprenorphine and be able to act as patient advocates for our service users. So a little bit of a history on it. It's not a new medication and has been around for quite a while. Initially introduced as a non-addictive opioid analgesic. I think many of us might be familiar with Temgesic and dispensing it. So what was found was that people who were misusing heroin were actually using Temgesic and other buprenorphine tablets to prevent their cravings from using heroin. So clinical trials came about after that. However, they did use low dose buprenorphine and for short treatment lengths of time, which weren't that successful because actually the heroin users were using quite high strength buprenorphine. So what developed from then was a sublingual tablet. The one we use actually in Ireland since 2007 and subsequently in community is a combination of buprenorphine and naloxone. But it actually has been available in many other countries for quite a substantial period of time. So the regulation around buprenorphine, on the left-hand side of your slide there, you will see a very useful guidance that is from the PSI on the use of buprenorphine in opioid substitution. And just to highlight the regulation, which did change in 2017 to mark the introduction of buprenorphine in opioid substitution treatment. So it replaced the 1998 misuse of drugs regulations. A little bit of pharmacology, because it's important to touch on this so we know how buprenorphine works. So it is a synthetic opioid that's similar to methadone. The two salient points from this is, number one, that it's a partial agonist. And what do we mean by partial agonist? So it means that it actually partially fires at the receptor. So there isn't a full excitation. So with methadone, which is a full agonist, you have full excitation of the receptor. With buprenorphine, you don't. So you have maybe less sedating effect and a milder euphoric effect. The second point is that it actually has a very, very high affinity for the mu receptor. So I talk about the mu receptor. There are 5 receptors, but the mu receptor is the one that we're interested in when it comes to drug addiction. So it has a very high affinity for the receptor, and that means that if there are other opioids in the system, for example, methadone, heroin, codeine, buprenorphine will actually displace any of those full agonists from the receptor. The ceiling effect that I refer to is demonstrated in the graph here. So naloxone is the bottom line, that's the antagonist, so you get full blockade of the receptor. The full agonist effect is methadone, etc. So the higher the dose of methadone, the more that you intake, the higher the opioid effect. So that's the issue with methadone, that's the problem. There's a higher risk of respiratory depression. With buprenorphine, you have the middle curve here. So as you increase the dose, there's actually a cap, you reach a ceiling effect, which is why it's considered safer in overdose. And during the pandemic, when we wanted to ensure that a lot of people who had drug addiction issues and couldn't access their normal supply were started on OST, there was a push to start people on buprenorphine. However, sadly, it doesn't always have this effect when buprenorphine is combined with other CNS depressants, which it often is, like benzodiazepines, alcohol, etc. The ceiling effect is actually null and void. So you do get the full extrapolation and the full escalation in the agonist effects. So today in Ireland, these are the brands of buprenorphine that we have available. Many people will be familiar with Suboxone. It is a combined buprenorphine and naloxone formula. It's quite a clever formulation because when it's taken sublingually, the buprenorphine is absorbed through the mucosa, but the naloxone is not absorbed. Subutex is the next image. Subutex is buprenorphine only. This is not a formulation that we would use very much because it is very open to misuse. So the instances where we might use it would be particularly if a lady is pregnant, many prescribers like to convert to Suboxone or like to convert from Suboxone to Subutex because just to narrow the risk of naloxone being absorbed. It is not clinically significant, the absorption, but just some prescribers like to err on the side of caution. Zubsolv is a new product that was introduced and licensed in Ireland in the summertime. And I'll go into more detail in my next slide. And then a product that many people might not be familiar with, and it's a long-acting subcutaneous injection, and it is called Buvidal. It is available in some of our clinics, our drug treatment centres, and I'll go into more detail in following slides. So looking at Suboxone and Zubsolv. So this is the comparison table between the two products, just to say that Zubsolv is not a generic, and in some of the doses, it is not bioequivalent with Suboxone. The license doesn't allow for switching. However, in practice, switching has been very successful, and we have quite a lot of experience under our belts now with switching patients from Suboxone to Zubsolv and also initiating patients on Zubsolv. It's been very well accepted, and I think patients and pharmacists are quite happy with Zubsolv. The key differences with Zubsolv are that it's available in 5 different strengths as opposed to 2 with Suboxone. It's a mint flavour as opposed to a lemon flavour, and some patients would have given out about the lemony flavour, which they don't like. They don't like the smell, they don't like the taste, and opioids would have quite a bitter taste anyway. From a pharmacist's point of view, the shorter dissolution is a definite advantage. So you don't have you have less supervision time in a busy dispensary. From a HSE point of view, it's 20% cheaper. I know this doesn't affect the dispensing pharmacists in community because, as you know, you receive buprenorphine on the free of charge scheme through United Drug. However, the HSE still has to foot the bill, and it is 20% cheaper. So that's why we're steering in the direction of Zubsolv. Buvidal is a really good option for certain individuals. So it's not available in community pharmacy, but I'm sure at some point it will become available, and that certainly is the plan from the National Office. As I said, it's a subcutaneous, slow-release formula of buprenorphine. It's given subcutaneously. It has to be given by a healthcare professional, so it's not something that you dispense to the individual to take home. There are different options. There are 4 weekly doses, and then there are 3 monthly doses. The great thing about Buvidal is that it actually offers a lot of flexibility to a patient. It also gives, from a psychological point of view, it means that a person is not tied to a daily dosing. The one thing we have found, I guess, is because patients are already coming in weekly and then subsequently monthly, is where the interactions are lower. So it's very important to maintain that added psychosocial element that's so important, along with the pharmacological interventions. So looking at appropriate patient cohorts, and again, I think this is important from a pharmacist's point of view, because we're dispensing to the patients, we're often the eyes and ears. They mightn't see the prescriber, beyond once a month. So if we see patients that maybe aren't necessarily suited to buprenorphine, I think it's probably important to relay this, to have a discussion with the patient, and also to relay it to the prescriber. So when might buprenorphine be appropriate? So as I mentioned previously, buprenorphine acts quite differently from methadone. Its effects are less sedating, so there's less impairment of cognitive and motor function. So this will suit many individuals, say if you're in full-time education, if you're in full-time employment, maybe if you have a lot of care duties, young children, maybe you want to move away from feeling like you are on a drug or a medication. So then buprenorphine might be very suitable. Also for patients that aren't entrenched in long-term heroin misuse, I think buprenorphine is a pretty good option. Another scenario might be if a patient has a treatment goal of detox. So it has been shown, or the literature shows, that it is easier to detox from buprenorphine. The withdrawal is milder than with methadone. Obviously, there's other instances. The most likely scenario that we see is where patients have QTC interval prolongation, and then by taking methadone as well, it's exacerbated. Also with drug-drug interactions, buprenorphine is a very useful substitution therapy option. Again, when is buprenorphine not suitable? And you might see these patients in your shop, and it's important to have that conversation, both from the patient's point of view, from the clinician's point of view. So if a patient is non-compliant, so they're missing lots of days, they're not going to reach that plasma level. Also, if a person is a polysubstance misuser, so they're misusing benzodiazepines, drugs, alcohol, then their cognitive function is impaired anyway. So it's sort of counterproductive then that they would be on buprenorphine. Obviously, their treatment goals are not aligned if they're using many other substances. Other than that, patients that maybe they're looking for say higher doses, they're looking for another drug that will give them that effect, that won't be that clear-headedness that buprenorphine provides. Briefly touching pharmacokinetics, again, relevant to the way that buprenorphine works in the body. So what does it do? The absorption, the distribution, the excretion. It has a very rapid onset, similar to methadone, peaks after 1 to 4 hours, but it is quite long acting, and after 35, 36 hours, you'll still have half of the substance left in the body. So what does that mean? It means that the long duration, in fact, enables an alternate day dosing. And I think this is probably an area that not a lot of pharmacists are familiar with, because I haven't seen it used so much in community. We have had in our treatment centres some individuals who have managed really well on alternate day dosing. So on Monday, they might come in, get a double dose. That does them for Monday and Tuesday, because the dose can last for 24 to 48 hours. Come in Wednesday, come in Friday. So that's worth thinking about, but bear in mind that the daily maximum dose of buprenorphine licensed is 24 milligrams. Interactions, Just be aware of drug-drug interactions. Because buprenorphine is metabolized by 2 hepatic pathways, it actually is not affected by drug-drug interactions as much as methadone. The side effects are very similar to methadone. The only one that's unique to buprenorphine is the precipitated withdrawal on commencement. And I think I might be running out of time, but just to reiterate, the precipitated withdrawal is very important to be aware of. And in summary, the person that's starting buprenorphine needs to be in withdrawal before they start. This is important. Otherwise, when they take the dose of buprenorphine, it bumps the opioid that is in their system off the receptors. They go into withdrawal and they feel really, really sick, and it's not a great start to treatment. So it's about assessing your patient, supporting your patient, and really preparing them. Preparation is key. If there's no preparation done, then they might opt out of treatment. I have some more counselling notes and some advice on missed doses in this slide also, which you can refer to also. And that is the end of my presentation. Thank you very much.
Good evening, everyone. My name is Meghan. I'm Chief Pharmacist in the National Drug Treatment Centre on Pearse Street. And this evening, I'm going to be speaking about current drug trends in Ireland, the prevalence and patterns of use. Let's move along there. Skip the slide. So what illegal drugs are used in Ireland? In order to establish what drugs are misused by the general population in Ireland, a national drug and alcohol survey is carried out every 4 years. So the last published one that we had was published in 2020, and approximately 6,000 adults were surveyed aged 15 and over. And results were as follows: cannabis 7.1%, ecstasy 2.7%, and cocaine 2.3%. So that gives us an indication of drug use amongst the general population in Ireland. For the purposes of this presentation, the data we're going to focus on is the data generated from the population engaging in addiction treatment. And the data source that we use for this comes from the National Drug Treatment Reporting System, or the NDTRS, which is the national surveillance system that records and reports on cases of drug and alcohol treatment in Ireland. But it is important to note that 69% of eligible services provided data to the NDTRS. So a significant proportion didn't provide data. So we can really only go with what data that we have. And even though it's set out in the National Drug and Alcohol Strategy that drug and alcohol services must return the data to the system, not all of them do. In 2023, only 43% of GPs actually return the data. So it's really believed that the figures that we have are really an underrepresentation of the number of people engaging in addiction treatment in Ireland. So in 2023, we had 13,104 cases treated for problem drug use. This is excluding alcohol treatment. Cocaine accounted for 38% of all cases. Opioids were 29%, with the majority of this being heroin. Cannabis 18%, and benzodiazepines 11%. Of note, cocaine actually in 2022, for the first time, surpassed opioids in terms of the numbers of people presenting for treatment. And 2023 followed the same trajectory in that we're seeing cocaine emerge as the most common drug of misuse in Ireland. So just looking at the main problem drug reported by age group, the first observation really is that the main problem drug from 17 to 19 is cannabis. Then in the 20 to 39 year cohort, it's cocaine. And then finally, patients over 40, the main problem drug seems to be opiates. And this really gives us a good indication of the aging population of patients that we have on opioid agonist treatment in Ireland. So that brings us on to cocaine. As I mentioned, this is the main problem drug in terms of the numbers of patients presenting for treatment. So as you know, cocaine is a stimulant. It can cause feelings of alertness and energetic, give people an energetic feeling, but it can also cause mood swings, some aggression, and violence as well has been known. In terms of physical effects, dilated pupils, dry mouth, loss of appetite, elevated heart rate are all effects of cocaine. It's increasing in popularity not only in Ireland but also across Europe. In particular, we're seeing an increase in the number of females using cocaine. And in terms of the numbers that presented for treatment for cocaine, 76% presented for powder cocaine treatment and 24% for crack cocaine. What is the difference between powder and crack cocaine? So powder cocaine is a white powder and it's usually snorted. Its effects start quickly and last for up to 30 minutes. Crack cocaine is usually smoked. It is made by chemically altering the powder to make crystals or rocks. It's given the name crack because when it is burnt, it makes a crackling sound. It's usually smoked in a pipe or glass tube or sometimes plastic bottle. And it is short acting. It usually peaks at 2 minutes and lasts for about 10 minutes. And once the high is worn off when crack is used, it's followed by a crash associated with cravings to use again. In terms of the socio-demographics of people who use crack versus powder cocaine, we primarily see powder cocaine in males, and 41% of the patients who presented for treatment for powder cocaine were employed, versus crack cocaine, we had 7% who were unemployed, or who were employed using crack cocaine, and there was seemed to be an equal distribution of males and females. In terms of our patients who presented for crack cocaine treatment, 65% of these also had opiate misuse. In terms of help available for cocaine, there's no pharmacological treatment. However, we do signpost patients to Narcotics Anonymous. We can also offer counselling or psychotherapy for patients who are looking at crack or cocaine addiction. In terms of cannabis, we're seeing similar statistics across Europe as we see in Ireland. Again, just to reiterate, it's very prevalent amongst young people, and it represented greater than 80% of cases of 19 years or younger presenting for treatment. We're seeing developments in the potency of cannabis. We're seeing an increase in the THC component and a decrease in the CBD component. So THC is tetrahydrocannabinol. This produces a psychoactive effect, but can cause impairment of attention, memory, and learning. It can also cause hallucinations and paranoid ideas. Cannabidiol, or CBD, is non-hallucinogenic, has anxiety-relieving properties, and no adverse effect on cognition. Just in terms of THC, it is a controlled Schedule I substance. CBD is not controlled under the misuse of drugs regulation, and it actually can be sold as a food supplement with no affiliated health claims. In terms of new cannabis products, so since COVID-19, the emergence of cannabis edibles, vapes, and syrups have come about in Ireland. Cannabis edibles or food products are food products that are infused with cannabis, and they can come in lovely, colourful packaging and really appealing to young people in terms of their presentation. The THC content is variable and unknown for the majority of these products, and some products have been infused with synthetic cannabinoids. One of the synthetic cannabinoids that emerged on the market was HHC, or hexahydrocannabinol, and that emerged in 2022. The long-term effects of this synthetic cannabinoid are not widely known and not fully understood. It's available legally on in high street shops in Ireland, and this is kind of a cause for concern, really, because it's not yet been regulated. The long-term effects are not fully understood in terms of the potential psychosis risk. Emerging evidence from 2 Irish hospitals indicate that it has the potential to cause psychosis. There were 2 Irish cases of regular cannabis users who experienced psychotic episodes believed to be as a result of vaping HHC, and it's currently being monitored by the European Union Drugs Agency. And that leads us on to benzodiazepines. So benzodiazepines as a main problem drug increased from 9.7% in 2017 to 11.3% in 2023. I've just linked the MMP prescribing tools and tips for benzodiazepines. Really, as a pharmacist, it's important for us to bear in mind these recommendations, especially in terms of counselling our patients with regard to dependence and the addictive nature of these drugs when they are being prescribed. In terms of if patients do present and are seeking detox from either prescribed or illicit benzodiazepines, it's best to do it under the guidance of a doctor or prescriber, and just to advise patients who may be dependent on benzodiazepines not to abruptly stop them, as there is always a risk of benzodiazepine withdrawal seizures. I've linked the community detox guidelines for benzodiazepines just down here. So the community benzo detox guidelines really, I suppose, in short, indicate that there should be a key worker involved for psychosocial supports for patients, and then a prescribing GP on board. briefly, I suppose what's in the community detox guidelines is a patient should keep a benzodiazepine diary for 14 days prior to starting the detox. And what is recommended is that the patient is consuming the equivalent of 40 milligrams of diazepam or less prior to being commenced on a medical detox. Generally, what's done is the benzodiazepine use is converted to diazepam dosage, and the patient is gradually decreased from their dose of diazepam. Approximately 1/8 of their daily dose is reduced every 2 weeks or so, but this is very patient dependent. So for our opioid agonist treatment patients presenting in the National Drug Treatment Centre, what we're generally seeing is illicit alprazolam, or what they call Tranex. They usually quantify it in trays. So sometimes trays can contain up to 10 tablets. Generally, they're approximately 1 milligram of alprazolam. 1 milligram of alprazolam is approximately equivalent to 20 milligrams of diazepam. So for our benzodiazepine patients presenting at the National Drug Treatment Centre, what we're seeing is usually the doses of illicit benzodiazepines that they're using are almost too high to commence a community benzo detox. So this is an issue that we're having and definitely presents challenges in terms of addressing community detox. So then in terms of the heroin and opioid European market, so in Europe, 1.3 million high-risk users. The Irish prevalence, there was 19,875 problematic opioid users. Currently, as of September 2024, according to the central treatment list, we had 11,453 people on opioid agonist treatment, so on methadone or buprenorphine. Synthetic opioids are a developing concern, and this is primarily due to, so 80% of opiates used globally come from Afghanistan. And in 2022, the Taliban announced a ban on opium production. So the area under poppy cultivation declined by 95%. And what this led to was a significant shortage in the global supply of opiates, and also the emergence of synthetic opioids, including nitazenes, which I'm going to speak about in a couple of slides. Just in terms of polydrug use, so the use of more than one drug was reported in over half of the cases, so 59% of people treated for problem drug use in 2023, and this is very similar to previous years. So you can see the drugs that are most commonly used together. Initially, it's cocaine and alcohol, then cocaine and cannabis, and then third, it's opioids and cocaine. So just important to bear that in mind. In terms of drug-related deaths, the data is published annually, but it's a couple of years behind. So the most recent published data is from 2021. So 354 drug poisoning deaths in 2021, and opioids were implicated in 69% of these deaths. We're seeing a similar percentage across Europe. Overall, opioids were involved in 74% of all drug-induced deaths, and the rates are increasing across Europe. In terms of the most common drugs implicated, methadone is implicated in many of the drug overdoses. 81% were polysubstance poisonings, and 88% had prescribable drugs implicated. I suppose in terms of the importance of counselling for pharmacists, we really should be counselling patients with regard to the risk of taking drugs combined, and also the importance of dispensing in installments or in phasing, and the importance of supervised consumption of methadone as well. The emergence of the novel synthetic opioids, nitazenes, also increases the risk of overdose. So that leads us on to the next slide. So this time last year, if you look at the warning that's just down in the right-hand side of the screen, it was actually the 9th of November in 2023 that we first saw nitazenes emerge onto the Irish market. And on the 9th of November, it was a Thursday morning, the HSE were informed of an overdose cluster in Dublin city centre by both the National Ambulance Service and the ED departments. By Thursday evening, risk communication was issued on the high-strength opioids circulating. There had been 34 overdoses in Dublin city centre in a 24-hour period, which was really high at the time. The risk communication was disseminated by the HSE, and then NGO Street Outreach also targeted at-risk individuals. A sample was actually obtained from one of the overdose scenes by Gardaí and transported to the Forensic Science Ireland lab, and then by Friday morning, analysis identified nitazenes, and in particular, it was the type of nitazene was N-pyrrolidinoprotonitazene that was identified, and this then a new red alert warning was issued on all electronic traffic signs. So you can see some of the pictures there. So initially, the overdoses were seen on Thursday morning, and by Friday evening, they had identified the substance that had contributed to all of the overdoses, and a lot of communication was disseminated to drug users and warnings were put up around the city to show how effective this was in alerting people to high-risk drugs available. By Sunday evening, no further overdoses had been reported. A similar situation happened in early December last year in Cork, whereby the warning system was really effective in actually communicating to patients the high-risk substances circulating. And also back in June 2024, we saw the emergence of nitazines being sold as benzodiazepine drugs, or being marketed as benzodiazepine drugs. And this led to about 20 overdoses back in the summer. But also, again, the importance of communication of these high-risk drugs really helped to get the word out there and stop the use of some of these high-risk drugs. Just a point to note on nitazines, the particular nitazine that was identified was N-pyrrolidinoprotonitazine, which has a potency of approximately 25 times greater than fentanyl. So when treating an overdose with nitazines, it's important to note that additional doses of naloxone may be required to reverse the overdose. And just in terms of in order to respond effectively and to be prepared, we have to know what drugs are in circulation. And we do this in a number of ways in the HSE. So one of the things that we do is syringe analysis, whereby the residues in discarded syringes is examined in our national labs. And we also do a wastewater analysis to look at what potential drugs are circulating. And then finally, we have health response to drug use with back of house testing at festivals. This is a picture from when this was piloted back in 2022, whereby people can provide samples of drugs in amnesty bins, and they're analysed. If anything harmful is identified, then warnings are circulated to people at festivals. So that's an example of a health-led response. And I'm going to pass you over to Norma for the remaining slides. Thank you.
So I'm going to go through some of the harm reduction principles that we've been talking about, kind of putting it all together. So just to kind of summarise, that harm reduction is what our service is about. And it recognises that drugs are harmful, but it tries to reduce the harm associated to both the public and the user, without any punishment, without any judgment, and it takes the user at the point they're at in time. So we have been through some of these. So you might want to reflect in your community pharmacy how many of these roles you fulfil, and perhaps there's a vision there to try and fill them all in, and to support the users as much as you can. So at the moment, you have opioid agonist therapy in many pharmacies, needle exchange in some. There's the possibility of naloxone, and I'll go through a bit of that towards the end. Hepatitis C treatment is in some pharmacies, and some blood-borne virus testing is rolling out as well. So opioid agonist therapy, as the girls have gone through earlier, it's shown to be the most effective way of reducing harm. That was officially done in reviews over time, in particular one in 2017. Now, just to point out that as the girls have said earlier, the drugs being used have changed a lot since then. That was very much a heroin-based picture. And now other drugs are coming in which have different harms. So maybe in time, what is more useful may be something different. For example, needle exchange might be important, or other interventions such as cognitive behavioural therapy, that might be more important. So the service is able to adapt all the time. So the aims of the needle exchange end of it is to provide clean equipment for those who are using and with the type of equipment that they need. And by doing this, reduce the risk of the spread of blood-borne viruses, such as hepatitis A, B, C, and D is a fairly new one that's come on recently, and HIV through education, screening, and treatment. Injecting drug users do make up a high proportion of those infected with hepatitis C, and many of those cases are not born in Ireland. The needle exchanges would encourage safe injecting practices, and to reduce infection or injury related to injecting, or to use alternatives to injecting, such as a foil for smoking, so that's harmful to the body. It would provide somewhere to dispose safely of equipment, and I can show you shortly what that looks like. And there's referral on to other services as an engagement piece. It might be the only time that somebody comes in touch with a healthcare professional. gives general advice on overall overdose prevention. So your risk of, this is the World Health Organization, this is a global picture here. Your risk of infection is 30% risk of hepatitis B from a needle stick injury or a contaminated syringe, 30% hepatitis C, and 0.3% HIV. So the Needle Exchange has about 90 pharmacies outside of the Greater Dublin area. It's free and confidential. It's part of a mixed needle exchange, so it's a mixture of pharmacies, fixed site specialists in the HSE, or maybe some mobile outreach. Now, a lot of the exchanges did take part in the Cork and Kerry area, but in the Midwest, there's a lot of a needle exchange happens, but that may be through those mobile outreach. A mix of different types of needle exchange happens throughout the country. These figures are monthly, so in the Southwest, there would have been about approximately 700 users, but there is some overlap in those figures. So in the pharmacy needle exchange, they provide free equipment, instructions how to use the pack and the contents, how to do safe disposal and return in the sharp container provided. So that little small one on the top is a very small container, and that's just to return 3 or 10 or 1 needle at a time. And then those that are returned to the pharmacy like that, closed up and sealed to be returned in the bigger container. And the pharmacists are not expected to be able to show how to inject properly, and that's up to an outreach worker or nurse to go through injecting technique. So what we provided, the standard needle exchange pack, which is a 1 ml needle syringe, some citric acid, some spoons, swabs, an information sheet. That's your heroin injecting pack, effectively. It can also be used as a subcut needle, so it can be used for injecting human growth hormone, for example, for steroid bodybuilders, but they can also pick up a steroid pack which has the intramuscular needles in it. And then we provide foil for smoking, and the shops are identified by a needle exchange logo on the window, and now we've revised a new logo that has the steroid kind of figures on it for those who provide steroid injecting equipment too. At the moment, most people are reported to be picking up for heroin injecting, but that's not reflecting what we're seeing in the treatment centres. We figure people are just using the habit and saying, yeah, we're just using it for opioids, because but the numbers are dropping a little bit over the last 2 years, by about 6 to 6% every year. So people are not using as much needles for injecting opioids. And about 10% of people come in for foil only. They don't pick up needles at all. It's a very small portion, maybe about 50 or so are picking up for anabolic steroids or for injectable tanning agents. So just to mention about the naloxone and overdose prevention treatment, it's a really important thing that pharmacists should get involved in. Whether it's educating patients about the risk factors at times where their opioid tolerance may be reduced, and they're listed there, and to go through very clearly what the steps are to do in an overdose, to try and break down the myths of what not to do. This is on the opioid substitution treatment prescription up in the far corner, and the 2-pack of Nixoid intranasal spray can be supplied under the medical card, GMS medical card scheme. So the fee does apply, and a GMS patient's GMS number is required for dispensing. If you have already done if you do vaccination training, in order to administer naloxone on site, if there was an overdose, you would simply need to go on to HSE land and do the overdose training, which is a short module. I think it's about an hour or maybe 2. And that's all you need to do. You don't need to attend in person. If you need to attend in person, you can attend module 1 and 2 on HSE land. You need to do your CPR course before doing that. But that will really only be valid if you're working within the HSE or an institution that is registered with the HPRA. For example, some of the Focus Ireland or Simon Communities, many of them have registered as an institution that can hold naloxone on site, and people working there, staff who are not medical, can do the training and they can administer. So they may present you with a stock order for naloxone injection or nasal spray, and you need to check the register on the HPRA website to see that they are a registered institution, they paid their fee to join and have done the training. And this is a private transaction that the agency must pay for stock. Thank you.
Thanks a million, Norma. Um, and thanks to all the speakers tonight. I think that has been really informative and packed full of information and links and resources. And to say there was a question there, the slides will be shared tomorrow and the recording will be shared. Now we've reached full time without even doing a question. I don't know, Grace, do we want to say to people that if anybody has to jump off, the link for the post survey is in there, and we might maybe cover one or two questions just quickly to finish. I'm seeing there's a good few coming in now. If there's too many, maybe we could answer some of them and send them out later. We've done that previously as well. But there was just one there maybe for Meghan. Would HSE not come under the Psychoactive Substance Act, even though it's not listed in the misuse of drugs regs?
Yes, so HSE doesn't currently come under the Act, and it's something that is being looked at the moment. There's just not enough publicised data in terms of the psychoactive effects of it, but it's being monitored continuously by the European Union Drugs Agency and in Ireland as well. But at the moment, it's still getting through that loophole because there's not enough evidence in terms of its psychoactive effect. Like all we have is anecdotal evidence as opposed to publicised evidence. So we're really just catching up with the trends.
There's a couple of other questions, but I think you actually answered them afterwards as you did the presentation. There's one about the naloxone, but I think that's covered as well in the training, maybe through the HSE land. There's one about have the HSE engaged with the PSI about pharmacist administration of Vividol. That's probably for Blaithin.
So at the moment, Vividol is only available through drug treatment centres in the north of Dublin and the National Drug Treatment Centre. At the moment, in the National Drug Treatment Centre, the pharmacists are administering. On our side, we have nurses who administer. The conversation hasn't started yet about rolling out to community pharmacy, but I think it will happen in the future. There's a big piece that needs to be negotiated there with PCRS and payments, etc. But certainly pharmacists, if they do the vaccination RESMA training, they can administer.
Thanks, Milena. I think there's a few more very specific questions there, but as we said, we're going to share the contact details, and the contact details are going to be up as a resource. So if anyone has any specific question, they can email it directly to some of the speakers from tonight. Grace has put up the post survey again there, and I suppose all it's to say is thank you so much. That I thought that was such an informative evening, so thanks a million to all the speakers, and their slides are so informative. I think I'll have them on my desktop to remind everyone to do a CPD cycle and to reflect on your practice from tonight. And then our next webinar is on the 27th of November at 8 p.m. and it's with Leonie Clark from IMVO. So looking forward to seeing you there. So thanks a million, everyone, and thanks to all the speakers tonight. It was brilliant. Thank you.
Thanks so much. Good night.
Bye-bye.
Good night.
Thank you.